So myself, Dr. Karthik Natarajan, I am talking to you from Chennai, India, and it's my honor to interview a senior pain physician from India, Dr. Pankaj Surange. Now, a bit about Pankaj. Now, Pankaj is actually a major in the Indian Army. So before he joined the pain physician, he actually was in the Indian Army, and he's a major in the Indian Army. And he is the director of Interventional Pain and Spine Center in New Delhi. He is also the secretary of the Indian Society for the Study of Pain. His qualification is MBBS from GR Medical College in Gwalior, MD Anesthesia from Army Base Hospital, New Delhi. And myself and Pankaj sort of finished FIPP together in the year 2009 in Budapest. So that's probably when I actually properly got introduced to Pankaj. So we were like probably number 3 or 4 in India. He went on to do his fellow of Indian Academy of Pain Medicine from the, he's also a FIAPM, and he did fellowship in spine endoscopy from Nanuri Hospital in Korea. He is also a recipient of the Pain Awareness Ambassador Award in 2015, recipient of Excellence in Pain Practice Award from the World Institute of Pain for his IPSC Center in 2017, recipient of National Pain Physician of the Year Award in 2016, and also the recipient of H.H. Rajmata Vijay Rajesh India Excellence Award. So Pankaj runs a very prominent pain clinic in Chennai, in Delhi. He also trains a lot of pain physicians. He runs fellowship programs, both online and offline. And he's also the dynamic head of the secretary of the Indian Society for the Study of Pain. So currently he's the honorary secretary for the ISSP, and he's doing a lot of wonderful work for the ISSP. So having introduced my good friend, let me ask him how
Karthik, so let me introduce you, or Pankaj might be introducing Karthik.
No, that's that's fine. So I'll maybe ask Dr. Das to say a few words about Pankaj before we start. Das, sir.
Yes, we know Pankaj, since the beginning of his career, and we can tell that is not just very young and dynamic, but more importantly, he can handle so many work together single-handedly, and with one of the very important passion, whatever he is doing in the core of his mind, that okay, he'll be doing something good for the specialty of the pain. So how the specialty of the pain can be, promoted nicely, how it can be developed further, and how it will be, reaching to each corner amongst the doctors as well as amongst the patient. And more importantly is, we need lot of pain physicians who will be mostly the full-time pain physicians dedicated in pain. So he's one of the very important motto to create those kind of pain physicians, and he's into that training since long. So welcome, Pankaj, and really we are very much feeling very happy, very proud that Pankaj is here to share his experiences, particularly to the youngsters. And this program is also being telecasted, means live streaming is done there in the YouTube, and also into the other channels. So
thank you, sir. Thank you very much.
So let me talk a few words about the Karthik also. Karthik, should I tell, or Pankaj should be telling about you? Pankaj, you will be telling, or I will be telling?
It's fine.
Karthik, you put that screen.
This is Pankaj show, so we might as well.
So about Karthik, like as Karthik mentioned, that we first met in Kolkata just before going for our FIPP. So that is where we underwent our FIPP.
That was in 2009. 2009 there was an FIPP preparatory course.
2009, yes, 2009. So just before for the exam, August 2009, September we went for the exam, And 2009 we met and we were sharing the same room in Daradia. And after that, for many years, we were sharing the same room wherever we were going. So, please don't take any any ideas from that. So Karthik is a great pain physician, very senior pain physician. We did, as we mentioned, that we did our FIPP together from Budapest, Hungary. And then after returning from there as a pain specialist, uh, that time he was in Chettinad College. He was an associate professor there and also in the pain medicine. And immediately after that, he conducted a very, very wonderful conference in 2011 and again in 2014, 15. That is ISSP. So first was the WIP conference and then ISSP conference in 2015. So those were the landmark conferences actually. After that, the scenario actually changed in India after that conference, 2011 conference.
Right.
He has been running a successful pain center. He was earlier with Apollo group of hospitals, where he started his full-time career as a pain specialist after leaving Chettinad. After that, he opened his own center, that is Synapse Pain Centers. Now they have multiple centers in Tamil Nadu. I'm not sure whether it is outside Tamil Nadu or not, but yes, they have
No.
2 centers in Tamil Nadu. And he's also into teaching. He's been conducting courses. He has been invited speakers to many national and international conferences. He's also the recipient of the Pain Physician of the Year Award and also the Pain Awareness Ambassador Award. Karthik, I think I've not missed anything.
Thank you very much. Thank you very much. Thank you for the kind words.
And one other important.
Right. So we'll actually get on with.
Karthik, just one
Yes.
about me, my
Yes.
achievement,
Yes.
about my achievement, that I was the first student of Dr. Das.
Yes, that was in
my-
2007.
2007. I was his first
2007.
student.
Yes. And
My
there was
achievement
another
is-
doctor from Iraq that time.
Yeah,
He
Ali.
was 3 that time. Yes.
Ali, Iraq, and myself, Ali, and from Iraq, and this guy from Nagpur. What is his name?
Vivek
Vivek.
Chakole.
We three were the first batch of Daradia. That time, Chaknor was there. What is it? Charnock.
Vivek Charnock Hospital. Right.
It is Charnock.
Right. So, thank you very much. Okay. So I have this long list of questions that I'm going to ask Pankaj. So let's see how this goes. So first question to Pankaj is, how and why have you taken the decision to become a pain doctor?
I think most of us who are in pain medicine most of us are anesthesiologists. I was also an anesthesiologist. I was working as an anesthetist. What I found while practicing anesthesiology is that whatever you do good, you are nowhere. Once you finish the case, you are nowhere. So that was the time when I started deciding that I should go into some super specialty where I should be doing something and I should be getting some recognition out of that. So that is the time when I was basically deciding, and my more inclination was towards the critical care. So I started moving towards the critical care. I started getting trained myself in critical care. I started getting involved in the conferences of the critical care. But again, after 1 or 2 years of doing critical care, I again felt the same thing what we are facing in the anesthesiology, that there's no how whatever you do with the case, how much challenging is the case, whatever you do, next day morning when the patient is totally awake, everything is done, everything is fine, you are again nowhere. A general physician will come and he'll say that it is his patient, and he is talking to the attendants, and you are nowhere. So that is the time when I decided that I should be going to some field where I should have my own patients. And that time in 2005-06, this was the branch which was just coming up. So that is the time when I started deciding that I should change over to pain medicine. So that is one of the reasons why I shifted to pain medicine. Yeah.
That's good. So what exactly?
Can I add a little
Yes,
bit
please.
about,
Yes, please.
means, I also had the almost same what Pankaj told. Like, when I was starting some escape route and how to go away from the anesthesia practice to the related branches of the anesthesia, I also same, started with the critical care, because, almost all anesthesiologists are inclined to the critical care, because critical care training facilities was there since that time only. Means anesthesiologist training schedule include adequately the critical care part. So critical care is an easy attraction for anesthesiologist. But the problem was what Pankaj told, apart from the appreciation, whatever you are doing inside the critical care room, nobody is knowing that. Not only that, it's very depressing. You are doing everything, out of ventilator, only few people will be surviving. So ultimately, job satisfaction also was, most of the time it is very depressing. So that was the another reason why I came away from the critical care ultimately.
True, sir. True.
Okay, so essentially they're saying they got individual recognition of the work when they become a pain physician. So it was professionally rewarding, is what they were saying. Right. So in your journey as a pain doctor, can you enumerate, I mean, tell us what are the milestones when you started off and when you shifted? You must have probably done anesthesia and pain for some period of time and then gradually come over to pain medicine. So how did you go about doing this?
Yeah. So when I decided to go for the pain management, that time I was working in critical care of Indian Spinal Injuries Hospital. So there I saw that lot of pain patients, and since Dr. Durija was used to come there, so that is where I got introduced to this pain medicine, and I saw that yes, definitely we can do something as an anesthesiologist. We can have our own patients. So I started inclining towards the pain medicine. Uh, I left that hospital, and then I joined Artemis Hospital. In the meantime, I started learning about the pain medicine. I started doing some workshops. I kept doing all those things. I joined Artemis Hospital again as an anesthesiologist also there. But again, the same problem was there, that nobody was allowing me to do any interventional pain procedures. So that was again a depressing thing. So from there only I went to DARADIA. So I wanted to have some good training before anybody could have have confidence on me that yes, you can do. Because without just on the basis of the workshops and attending some conferences, obviously nobody will allow you to do any procedure, especially in the corporate hospitals. So that was, but the only problem was that time was there was no training whatever we have nowadays. That time it was not there. Fortunately, I found Daradia. Basically, I found found you on the website only. I saw your Daradia on website. So there I saw that Daradia is one center. Then I approached Dr. Das. I wrote a mail to him that I want to undergo some training. So initially I approached this Coimbatore. There is one palliative care hospital is there, Ganga Hospital. So I approached them, but they said ki we only do some acute pain cases. We are not doing chronic pain. So we are not a good choice for you if you want to go for the chronic pain. So I consulted Dr. Das. I wrote a mail to him. Immediately I got a reply from him that yes, I'm starting some training program. So why don't you come and join me in that program? So this is, I was so lucky that that is the time when I was searching. He came out with one innovative ideas of starting with the pain medicine program. And this is how I joined Daradia as a trainee.
Right. So for a young pain physician who is basically an anesthesiologist and who's interested in pain and who's got some training in pain, so what do you would suggest them to sort of do both practice for some time and then stabilize and then switch over, or what would you suggest?
Yes, so Karthik, we know that whenever we are in the initial phase of our practice, that time financials also we have to see. So this also happened with me also, that I did my training under Dr. Das in 2007. After that, we went for the FIPP in 2008, sorry, 9, 8, sorry, 2008, we went for the FIPP. Uh, after completing this FIPP, when we got our result, So obviously, when you have a degree which is a internationally recognized degree, and we are the fourth, fifth person in India, you are on a little bit high that, now I'm a pain physician, great pain physician. So so I jumped to the pain medicine, that I don't want to practice anesthesia now. But soon, maybe after 6 months or 8 months, I realized that with this kind of practice, I will not be able to survive financially. It will be very difficult, and it was getting difficult for me also. So I again went and entered into anesthesia practice. Uh, but what I did was, I never switched over suddenly into the pain practice. What I did was, initially I was working in a corporate hospital. So we had a facility that you can choose 2 days of the week, 48 hours you have to complete. So what I did was, I chose 2 days in a week. So 24 hours I was doing. So like Tuesday and Thursday, I used to practice anesthesia all throughout the day there. And rest of the 5 days, I used to go to other hospitals and used to see the pain patients. So this is how I started. Then when I started developing my practice, then in the daytime, I wanted my daytime free. So for next 3 years, or almost for 2, 3 years, what I did was, till 2011, I I used to practice anesthesia only at night. So I joined a hospital in the night only, for the night, from 8 to 8, 12 hours. So every alternate night I used to do night duties, and daytime all the 5 7 days I used to go to some different places, peripheries, not the Delhi, because that time it was very difficult to practice in Delhi as a just a beginner. It was very difficult. Nobody was allowing you to. Nobody was ready to give you OPDs. So I chose to select some centers in the peripheries. So I used to travel to all the places around Delhi.
So
And in the,
how far it was from Delhi?
so, sir, there are various places, like they were around 1 hour journey from Delhi. Around 1 hour journey.
1 hour means around 30 kilometers.
Around 30 to 50 kilometers. Yes,
Okay.
30 to 50 kilometers was the range.
And how many centers?
So 5 centers. Every day I used to go to some different centers. 5 days in a week. 2 days I used to practice here only in Delhi. So what I done was, I kept these 2 days for the OT purpose. So luckily there was a center which was coming up in Dwarka region only hospital. The owner of the hospital, he himself was an anesthesiologist. So he allowed me to give his OT. So I used to roam around all of these places. I used to collect the patients and used to call them on those 2 days, on Saturday and Sunday, for the procedures.
So very, 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 tough time.
Yeah.
At night you are doing, anesthesia practice, and at the daytime you are roaming around 30, 40 kilometers. So very tough time.
Yeah, almost. So I always like in the night, if when I'm leaving at 7 o'clock in the night, and then next day in the night I used to come back, because from there only I used to go to other places. 8 o'clock I used to leave from there and go to some other places.
So essentially, what Pankaj is trying to say is, it's maybe a good idea that you overlap your practice for about 2 3 years till you are financially stable, and you have picked up a reasonable amount of practice in terms of number of OPD patients. And then, if you're confident enough to leave anesthesia and switch over to pain. And also, as a physician, you all know that to establish a practice, it can take anything between 5 to 10 years realistically. So most of the time, it's just that people have to recognize that you are a specialist and you are doing so and so sort of these conditions you are treating and these treatments you're offering. So establishing a practice for somebody who's not trained in OPD is the tricky part. So that's something that the juniors should take in mind. So overlap practice for some time and then switch over would be the way Pankaj has described it. Right?
So Pankaj, how long was your incubation period?
So incubation period, I'll say around 5 years, sir. 5 years.
But probably for the newcomers, this incubation period has shortened a little bit.
Now it is not that because now we have a lot of trainings available. So many things are happening in the pain, and they can learn fast, and they have backup also. At that time, there was no backup also. So that was one of the he remembers, I used to call whenever I used to get into some trouble. I used to call you, and then
Yes, I can remember. In that hospital, hot hospital, you was telling.
absolutely yes.
I went to that hospital also.
Yeah, absolutely. So sir came to Delhi for some other work. So I caught him there only, and I said, sir, I have some few difficult cases. I want to show you those cases, and you have to perform those procedures. So I collected those patients. 3-4 patients were there, and he did. So what he did was, he never did himself. He said, you do it in front of me, and that is what I learned from you, sir. And I'm doing the same thing. I'm applying the same thing. Whenever people call me to do some procedure, I tell them, ki you do, I'll stand here and you do the procedure. So this is how I learned from you, and this is what I'm teaching also.
Good. So you're saying about 5 years of overlap of practice, and once you're confident and once you have some backup, then that's when you shift over from anesthesia to pain. Yeah, probably you're right. Earlier, since nobody knew anything about pain management, the duration for us to establish practice was longer. Now the training is better and everybody knows about pain management. So probably establishing practice is
Kartik,
a little.
there are many youngsters here joining in the participants. Can you ask some of the very young one? How much was their incubation period to leave anesthesia practice completely into the pain?
Dr. Jeshnu Tople, are you there? Can you hear me? I
Yes,
can
sir.
see. Yes, you finished 1 year training in DARADIA, if I'm right, correct?
Yes, sir.
So tell me how you sort of went back to your town and then how did you pick up practice?
So practically speaking, I am from a smaller.
Okay.
Wanted to go back into Nagpur,
Mhm.
but it is getting difficult to find an attachment as pain specialist at any corporate hospital in Nagpur and even in medical colleges. So
Right.
fortunately, I find a medical college about 80 kilometers from Nagpur, which is Wardha, where last time as a IPM examination was conducted.
Yes.
And these people were ready to give me an attachment as a pain specialist only.
Mhm.
And they needed a commitment from me that I should be taking care of some cath lab and intervention radiology cases in
Mhm.
case they need certain anesthesia backup.
Okay.
So with that commitment, I have joined here about 1 year back.
Mhm.
They have given me a separate OPD over here.
Mhm.
But still I'm finding it difficult to get the patients into the OPD from registration counter or through by advertisement, because you see the top-notch people who I can't get the names, but the top-notch administrative people who are sitting over here. This is a private medical college, sir. The top-notch people who are sitting here in the administration are. I am finding it difficult them to pursue that. This is what should be done for the benefit of the patient and as well as for the revenue generation. But they are more into revenue generation, and I'm finding it difficult to pursue them that this would be a good aspect for revenue generation for the hospital too. But I'm still struggling after 1 year also, but I hope I'll make them assured that it will be a good aspect for them also for revenue generation. But till now, the practice due to this COVID era again has sunken down.
Yes, Dr. Jishnu, I understand what you're saying. So, see, the thing is, see, I was in Apollo full time just for the sake of for the beginners. So, what we, myself, Dr. Das, and Pankaj, we all realized early on in our careers is it's fine to be in a corporate hospital, it's fine to be part of a team, but essentially, if you see everything is business, so you need good business, right? So you need more patients, you need more money. So if a patient walks into the hospital and they go to the pain management, compare that to the same patient going to spine surgery. Okay, so if you look at the business perspective, the hospital administrator would rather have this patient undergo a big surgery from the spine surgeon than do a small injection from the pain physician. This is if you take the patient's welfare out of the equation. If you just see as a business perspective. So we realize that pain clinics may not thrive that well in tertiary care hospitals. That's why most of us came out and started our own centers. So that may be a thing that as a young pain physician, you should keep in mind. You can be attached to a tertiary care hospital as well. But if you want to do as a full-time pain practice, it may be advisable for young pain physician to start your own centers. Initially, you can overlap it with either private practice or corporate practice of anesthesia, and then eventually switch over to full-time pain practice in a hospital standalone pain clinic. So that may be a little easier, because you sort of, in a corporate hospital, it's like working with your hands tied behind your back. So sometimes it can be tricky, because obviously the surgeons are involved, the administrator wants more business. So it is a little tricky. If you're in a medical college, it's fine, because there's no money, may not be involved. But if you're in a tertiary care hospital in a city, so business is important. So if you want to develop pain practice, a standalone pain clinic may be better and easier. It'll take some time to establish, but in the long run, this will be beneficial. Like if you see most of us, most of the senior guys, Pankaj, Dr. Das, myself, all of us were Dr. Palak. So what we all realized earlier is, if you go separately and start a pain clinic, it's a little easier, just for the sake of the juniors.
Yes.
Right. Coming back to Pankaj. So in your pain practice, what is your most memorable day and why?
If you talk about a pain practice, the most memorable day was that was in 2010, when I put my first spinal cord stimulator. And why it was so memorable, because firstly that it is such a big procedure which I was doing. So that time spinal cord stimulator means something very big. So where I was doing this procedure, like a hospital was totally on toes, something is big is happening. In fact, they did after that, they did a lot of marketing on that also, on that part, that a pacemaker is put in the spinal cord, something like that. So that was a day when I was very happy that I was doing the spinal cord stimulator. Why it was so memorable, because the condition of the patient was very severe, and when I put this spinal cord stimulator lead inside, when we connected with the outer generator, on the table itself, this gentleman, he was 70 years, a very qualified person. He was an ex-IS officer. So he said, "Doc, put the permanent one right now. I want it right now." So that was his on the table when we switched that temporary one. When we switched that on the table itself, he said, put that one on inside to me." So obviously that was my first, no experience, nothing. I was zapped what to do. He's requesting to put a permanent one. So, Naveen, Inmito guy, he was there with me. I looked at him. He said, "No, don't do this. Don't do this. Put it inside." So that was the most memorable day. I remember that incidents.
Good. Fantastic. Nice to hear that. Okay. So in your pain practice, which is the worst day, and why, something that you want not to happen and to forget? What's your worst day in pain practice?
I'll not say that worst day, but yes, definitely in any practice, I think we all face some challenging cases. And again, the most memorable is, again, I still remember I called Dr. Das that time also, immediately from the OT itself. So I was stuck actually in that case. This was again in 2011 somewhere. In a corporate hospital, I was doing barioplasty. So the moment I entered inside, the pus started coming out. It was a compression fracture. On the MRI also, it was mentioned a compression fracture, and there was some blood collection inside the vertebra. So the moment I entered inside, the pus started coming out.
Okay.
So I was stuck. Now what to do? Now we have learned that whenever you have a infection, that becomes a contraindication for the intervention. Now I'm already inside, and pus is coming out. Now what to do? So from the OT itself, I called Dr. Das. But unfortunately, Dr. Das was not available. He was somewhere busy. He couldn't pick the call. Now I was again stuck. What to do now? So I was just thinking what to do, whether I should come out or whether I should inject cement or not. So almost 30 minutes I just wasted in thinking and contacting some people and thinking, whom should I contact? Then I tried to contact that time. You know, remember, sir, Dr. Patel from USA.
Mm.
So Dr. Patel, I tried to contact him also, but that time probably that was his night time. So obviously he didn't pick up the phone. So I was stuck there. So like I was actually sweating like anything. I
Mm.
usually don't sweat, but that day I was actually sweating. What to do now? So that was one of the I can say I will not say it's a complication, but it was a very challenging case for me. Yes.
So what did you do in the end?
Yeah. So that was again interesting thing. So what I did was what I thought that time, uh, since I'm already inside, the pus is coming out. Let me take out the pus. Now we know that when you inject cement has exothermic reaction. It might kill the bacilli, whatever they're inside. We'll have a good, maybe we have a good result. Fracture is already there. So
Mm.
that was the thought which came into my mind, and I injected cement and I came out. Luckily, she was fine. But when I after that the next day or the same day, I think same day evening, when I again Dr. Das. So Dr. Das said, "Ki you did a wonderful thing." That was his comment. You did a wonderful thing because already you are inside. You are taken out the pus. Then what is the problem? You injected cement. It will take care. So that was his reply. Uh, and also I had called Dr. Patel. So he also called. So I had told him that this is what happened. He said, "It's okay. You did a wonderful thing. It's okay. But only thing is that there are some remote possibility if you inject cement. There is some possibility that the baseline may move to from one body to other bodies. That is one of the possibility. So as it is, you are going to start medications, ATT, because that was tuberculosis. We could make out that it is a
Mm.
tuberculosis. I will
Okay.
start the ATT. So
Mm.
luckily, it all went well, and that was come out. It came out to be a very good result also. But that was really challenging case for me. And you can think that in 2011, I'm talking about 2011, we just started our practice that time. So that time, just such kind of condition. Yeah.
Right. So you basically had a bad complication that day.
So that is yeah, challenging. I will say that that's why I always say that it's not a bad case or something. We should take them as a challenging cases and take them as a challenge and then do it. Complications may happen with anybody.
That's right. So just a word for the juniors. Now the thing is, to take a challenging case is fine. Now the thing is, in the initial part of your practice, I would advise you to be rather safe because you are going to be starting a practice where you'll be stepping on the foot of a neurosurgeon, neurologist, orthopedician, a lot of people who are already established specialties, and you're trying to establish a new specialty. So if you go into a hospital and if you were to do a pain procedure, and in the initial part of your practice, if you have a complication, you're basically giving a reason for other specialists to put you down, saying that so and so has done something and he's caused a complication. So initial part of your practice, let's say 1 or 2 years or 2 or 3 years, when till you establish and you start producing consistent good results for your procedures, play it safe. And then once you're established, you can do procedures which may involve a little bit more risk. You just imagine somebody who's already established and who's doing practice, and if he has a complication, whoever has heard about this case would probably say he is a reasonably good person. I mean, reasonably skilled surgeon or reasonably skilled physician. And once in a blue moon, something does go wrong. So something may be wrong with the patient itself. So whenever you're doing a risky case, initial part of your practice, try to stick to safer cases. Once you're reasonably comfortable, you can play around a little bit, take slightly more risky cases. So that's something that you want to keep in mind.
Not only that, Karthik, that what I always tell, that always learn about all the possible complications, and how to come out of those complications. Whenever you are starting the cases first time in your life, even if it is a transforaminal epidural, even if it is a facet joint, whatever, when it is first time, once you'll be doing it first time in that procedures. You might have done in the cadaver workshop, you might have seen seniors are doing, but you'll be doing it alone in your own patient. So in those situations, we should be always reading all the possible complications and how to recognize those complications, how to come up out of those complications. And some seniors should be available to consult, or some seniors should be there if in case you are in trouble. And presence of mind is also important. Like Pankaj, when he was not finding anybody, not me, not Dr. Patel. So ultimately, presence of mind, so that is very important. Never lose nerve, never get too much confused. So always keep your mind, be smart, and presence of mind is very important.
Right.
That also, we remember that during those days, whenever we used to take the patients inside OT, some major cases, a lot of people used to have an eye on us. that was always there.
Yes.
Practice. And that is also true that in your initial practice, you get a lot of difficult cases also. Most
Yes.
of our patients, whatever you will get in your initial practice, you will be getting very challenging cases.
That's true. That's true. Right. Okay. So moving on to the financial aspect of it. Now, obviously, we all have families, so we have to take care, and money is important in any practice. Ultimately, it's business. So, as a physician or as an anesthesiologist, how much does an average anesthetist make? Whoever your colleagues, whoever who studied with you, how much they make in the city or something. So, when you are a pain physician, compared to the anesthesiologist, when did you feel that, okay, now I can make as much as the anesthesiologist, or now I can make more money than the anesthesiologist? Financially, when did you feel you're safe?
Yeah, so Karthik, that is also financial thing was also again, here also comes a very challenging situation, what we faced during that time. As I mentioned that since the practice was not that much, we were not getting much patients. So finance was one of the issue. Definitely it was an issue. But as you mentioned that getting patients or getting OPDs in the tertiary care hospital or the corporate hospital was also difficult. So initially, definitely I tried after completing my FIPP, I tried that also. I went to certain hospitals, some corporate hospitals, and asked them to give me some, because now I have a FIPP degree, then international degree I have. So I was very confident that I'll get something somewhere in the corporate hospital. But unfortunately, I was not getting anywhere. Wherever I was going, they were initially asking me to go into the anesthesia practice, enter into the anesthesia, and then from there you start doing pain practice. So I was not very keen for that, because earlier also I had suffered those things, that once you are in a junior position in an anesthesia department, nobody will allow you to do any procedure, because then nobody wants you to do something extra. And as it is, anesthesiologists are always in a demand. So that was another thing. So so as you mentioned that, so this is around 2011 somewhere I started deciding that we used to discuss all these things with Dr. Das also, and he also used to say that you should have your own setup, then you will progress. Otherwise, it is very difficult. So that is what we were facing also. So that obviously that time also financial conditions were not good. So in 2011, I took a personal loan, because now when I went for the loan from the bank, they were not ready to give me the loan, because they were looking for my previous financials. What is the previous financials? That was not good. So obviously I had to go for the personal loan. So I took a personal loan of around 20 lakhs that time, or at a rate of 15%, 1.5. So that was that was very high. But I took a decision that I have to open my own setup. Then only it is possible. So that I took in 2011. In 2012, I started my own setup. Uh, After starting setup, is again it was a big challenge, because now you have expenses. Now, if you are running a center, you have a loan, 20 lakh rupees loan. You are giving EMIs on that. You are paying rent for this setup, and staff and all these things are there. Now you have expenses also. So if you financially, in fact, initial 3 years was very difficult. So I'll say that at par I came in around 3 years. at par. After that, definitely there was a good improvement in the financials, and I'll say that after maybe in 3 years, I was very much comfortable, very much comfortable.
Right. Okay. So the next question
Yeah.
is the million
So,
dollar question.
Karthik, I'll be also adding the same thing, you know, hot experience what just Pankaj told, that I also used to get the same, you know, the corporate hospitals give the same condition. Okay, come as an anesthesiologist, then we can give you a, you know, the clinic, OPD. And as soon as they are going into the OPD with these conditions that they have to do the anesthesia, and now the senior anesthesiologist uh, do not allow them to do you know, pain OPD, or do not allow them to do the pain procedure. So this is one of the trap. You know, most of the juniors, you know, feels this trap very much.
Right. Okay. Now, next one is the most important question of the whole show. So we just saw Dr. Jesnu and Dr. Animal Milton say that they have a lot of difficulties to establish a practice. So you are trained, you have your own clinic, and you have starting pain practice. So what should be, as a young pain physician, what should be your strategies to establish pain practice? How will you establish it? How will you market yourself? So what are the tricks of the trade?
Yeah. So one thing which I was very sure about my practice, whenever I'll start my practice, pain practice, I was very sure that I'll not be dependent on anybody for my practice. That means I will not go to the surgeons and ask them to please send patients to me. So that was my first promise to myself, that I'll not go to here and there to other places. I'll develop my own practice. It will take time. It does take time. Definitely it takes time when you develop your own practice. So I'll give you one very good incident which happened with me also. Uh, so there was a hospital in Gurgaon, a big corporate hospital. Uh, so I was called by a neurosurgeon there. He was a big name, very big name. He was a professor of head and professor of AIMS, All India Institute, and he had joined that hospital. He was the chief neurosurgeon there. So he called me and he said, "Ki, why don't you join my team as a pain physician?" So obviously, when such a senior person is calling you, and I was very happy with that. That I'll get a good breakup here. So I was struggling that time, obviously. So I accepted that offer. I joined that hospital first day, and since his practice was like roaring practice, so I was very sure that I'll get at least 4 to 5 patients every day. That was my expectation with that hospital, and this is what happened. Actually, this is what happened. On the very first day, he gave me 2 patients for interventions. For next day, he gave me 5 patients for interventions. But what happened third day? So third day we were on the round, and we did a round also, and there was some patient, and he told me something to do some procedure. I said, "Sir, can we do this procedure? Because I think that it is a." So he started shouting at me in front of everybody. He was like that only. He used to shout everybody. Okay, I said, "He's a very senior person. I should not take that into on my heart. That it's okay. I'm also learning under him." But when I was sitting in OPD, this finance guys, people, they came to me to sign something. So what had happened, whenever we do procedure, we used to put our charges there. Okay, so there were a bunch of the 5 procedures. So they brought these documents to me, and they said, "Sir, you have written this much charges. Dr. Mehta, Dr. Mehta, he has cut it into." So like I was putting around 10,000 charges, 8,000 as my procedure charges. He had made it to 1,500 rupees. He had cut all the things and he made 1,500 rupees. So that was my third day. I said, I cannot work like this. If I'm doing some procedure, I want my charges. So that was the third day I left that hospital. Firstly, I said, "Sir, I cannot do like whatever you are saying, I'll do that. It is not possible. Let me also examine. Let me examine. Let me decide what I should be doing on this patient. And secondly, charges, I should be putting my own charges. Why should you putting? So what he said is, epidural का कोई 10,000 रुपए लेता है, 1500 रुपए ले. So that was I said I cannot do like this. So that is the time when I decided that I cannot work in a corporate hospital. I have to have my own setup, and that's why I took a decision to take a personal loan at 15% also. So one thing very important is that don't ever depend on any surgeon or anybody and go and ask them to refer patients to you. Second very important thing is never ever accept whatever they are writing. What if they are giving you in writing that you do this procedure, you do that procedure? Never accept that. Always tell them, sir, if you have a patient, if you want to refer, you refer this patient to us. Let me decide, let me examine, let me decide what is required. Okay, you go and discuss with them, no issue, no problem in that. But never ever do that if somebody is written, do this block, and you think that it is not required, something else is required. You must put your foot down there. Third is marketing. Do your marketing. Own marketing. That is the most important thing. Even if you are working in a corporate setup, you have to do your own marketing. They will never spend money on you. Definitely, they are not going to spend money. They will never have budget on for the pain medicine department. So you have to do your own marketing. Whatever money is required, you put from your pocket, and you do your own marketing. So this is how it will take time. This takes time. This path takes little time, but it's a full-fledged, it's a foolproof path. Once you develop the practice, then you start getting patient to patient. Then there is no, the sky is limited. But if
Right.
you're dependent from the very beginning,
Pankaj,
yes, sir.
Pankaj, here you are very much true, and I have seen in my practice as well as many of the juniors has told me the same thing, that patients are referred to them with an advice to epidural, referred to such and such person, some pain physicians or a pain clinic for epidural, because epidural is one of the commonest thing. So as if surgeons are not so. This is what you have told is excellent, and all pain physicians should be examining the patient and should be taking that the own decision what to be done. Because even surgeons don't know what exactly we can do. A lot of things they are not aware what are the domain, what are the areas, what are the interventions, what we can do. Many times it is not. But problem is for the junior. Many times they do not have that much of strength to say no.
Right.
Sometimes it is difficult to say no to the senior.
Right. So essentially, for the juniors, the take-home message is don't depend only on referral patients. Try to do your marketing. The emphasis is on reaching out to the public than reaching out to your colleagues, because referring a patient is his prerogative. The surgeon may or may not decide to refer a patient to pain management. He has no obligation whatsoever to refer a patient to so-and-so specialist. So the emphasis is on going to the public rather than going to other colleagues. Yes, you make them aware, you inform, you educate, do the awareness programs, tell them that so-and-so facility exists and so-and-so procedures can be done on daycare basis, whatever the properties are. But at the same time, go to the public, which would be more important in the long run than trying to talk to your colleagues. Now, a lot of times the young pain physicians come and say that, yes, I went and talked to so-and-so people in my hospital. They have not referred any cases to me. I'm getting very frustrated because there are no OPDs. So that's why it is always better to go to the public. And if they come to you and you are the primary physician, you can also decide what is best for them rather than depending on somebody else directing you to do this procedure, which may be a good procedure, but may not be the most effective procedure. So the take-home point is go to the public, create awareness, do marketing for yourself. Pankaj, again coming back to you, individual pain clinic, you've just set it up. What else should the pain physician be aware of to make the clinic more prominent in terms of should he be more social media active? Should he get a website? Should he do online consultation? So what are the other tricks of the trade in pain practice?
Yeah, so in the last 6 months, if you see, the practice has totally changed. This corona has changed it completely. The practice has totally changed because of this corona situation. Earlier also, if you remember, we have discussed earlier also this point, that the most effective is online marketing. That is the most effective way of doing. But when we started practicing, when we opened our center, that time print media was also good. That was also good at that time. Uh, but now the scenario is totally changed now in the last 6 months. Now the print media is totally out of your marketing budget. It should be totally out of your marketing budget. Online marketing, your website is really very good. A website, you should have a website, because without website you cannot do any online marketing. Firstly, now this online consultation also has become a very important tool for your revenue generation, because with this online consultation now you have reached to people from all over India. If you have an online consultation facility or the second opinion facility, in that case you can reach to all over India. People sitting in Tamil Nadu can consult you now. So this we have seen in the last 3-4 months only, that every day I'm getting around 4 to 5 patients online only, and they are from the different parts of the country. So online marketing is the most important thing these days. Secondly, when you start your own setup, own clinic or the setup or the procedure or some whatever the center you open, that time you should go for the uh, camps, free camps. Why it is important? There are two reasons for that. One is that you want people to show your center. Okay, that is one important thing. People should come to know, at least in your vicinity or in your area, that there is some center like this. For that, camp is very important. Obviously, when you do camp, you will do some marketing for that. So marketing will help you. Okay. Second important, what is important when you start your practice is that when you do free camps, you're not tensed while seeing the patients. Whereas if you're charging a patient, you have a very big tension on your head, that you have to give a very excellent results or whatever you have to give. But if you have doing camps, you're seeing multiple types of, you're seeing multiple different kind of patients, and that gives a confidence also. Because whenever the patient comes to you, they see the confidence on the face of the treating physician. And that confidence will only come if if you're seeing multiple patients. This is the biggest problem with the anesthesiologists when they start their practice. We are not confident in seeing the patients in OPD. We are not confident in writing the prescriptions. So that is one of the drawbacks with anesthesiologists. So this confidence only comes when you see multiple patients. So keep doing camps. You go to different places, do camps, go every month somewhere outside in the periphery, do camps there, see 50, 60 patients. You know, then you get a confidence to handle a patient, 50, 60 patients or 100 patients in a day. You are seeing, when you start seeing such number of patients, such variety of patients, then you start building your confidence. And that is absolutely reflected on your face. And that is what patient sees. They see the confidence on you. So I'll say that right now, if you're just starting your practice, go for good camps, do your own camps. Don't depend on any other hospital or something that they will conduct camps for you. Nobody will do that for you. So you have to do your own self. Even if you're working in a hospital, you spend your money, contact these marketing people, tell them that I'll spend the money for the marketing, whatever is required, 30, 40,000, whatever is required for the marketing, but arrange a camp for me. That you can also do. But if you have your own setup, it is always better to do it at your own center, so that you have a lot of footfall also.
Right. So one thing that Pankaj said is very, very important. See, when a patient comes to you, it takes less than 5 minutes for them to know how confident you are. A mature adult can pick it up in like 2 minutes. So you will get that confidence not by coming in a Benz car, not by doing fellowships, not by doing anything else. You will get that confidence only if you have already successfully treated more and more patients. So, and the more confident the patient is with you, more likely, very commonly, you find that somebody comes to you and then you finish your consultation. They will say, my relative is also here. He's also having back pain. Or the next day, he brings somebody else. So, this is called word of mouth marketing. So, that is very, very important. And that is probably the number one source of more patients coming to you. And that is directly proportional to how confident a physician looks like. So for you to be confident, you need to have adequate knowledge. You should be able to answer all the questions that the patient may throw at you, including things that they read up in Google. You need to be able to examine them. You need to be able to communicate with them. And you should have pretty much all the answers for whatever they throw at you medically. So that you will get only after you see more and more patients. And you will realize that after you've done practice for 4 or 5 years, pretty much your set of few thousand patients will keep coming back to you. They may even come back to you and say, I have so and so other problem, ENT problem, whom should I go to? So that you will reach only with a little bit more experience. So that confidence that Pankaj talked about is very, very important. That is something which you should have good textbook knowledge. You should have procedural skills, and you should see more patients. That's the way you will get. Dr. Gadir is here from Sudan, so let me quickly ask him. Dr. Gadir, can you hear me?
Hearing you.
Yes, Dr. Gadir. Good evening. So, yeah. So, can you tell me? We are talking about practice in India. So, you are the pioneer in Sudan. So, how did you sort of establish your pain practice in Sudan?
First of all, thank you for this nice idea, which give the juniors very important part of the practice in the difficult days, because in the past days there is a very big difficulties how to get the knowledge in pain, how to find somebody to teach you or to train you in a pain management. So nowadays I think there is a lot of doctors, there is a lot of professors, a lot of training centers training people in pain management. Also, there is a lot of books there to teach people in pain management. So we are unlucky, say like this, we are the generation of that difficult days. So we are coming to practice pain. As you know, we are together in the same period in DARADIA, why I have spread 2.5 years in UK to take some information in pain management. In my difficulties that has faced me in Sudan in the early days, it was, hello?
Yes, we can hear you.
Yeah, my difficulties in the first days, because as you know, pain management in Sudan has been practiced by orthopedicians regarding the low back pain and the others, and has been practiced by the oncologist and the internist and the post-operative pain and the other parts. So the differences between the acute pain management and the chronic pain management and the view of these two parts are missed. So one of the things that has been taken as message from DARADIA practice from Dr. Das, I said, we are going to the area where it is very difficult to establish your own work, on pain clinic, your own training center. How can I do in this situation? He said, you have to start with some problems, some syndromes that are others cannot solve it unless you. So I follow this. We follow this advice. We follow this message. When I came in Sudan, I started with the most difficult cases that the others cannot solve it. For example, the facet joint syndrome, the failed back surgery syndrome. So these are the mistakes has been done by them. So they need somebody to correct it. They need somebody to do it or to do something that can be solve the problem to the patient, and it might save their practice because they are doing surgery and the patient is not to find what he is seeking. So the difficulties in Sudan has been gone. Nowadays, we are the pioneer definitely in Sudan and the in the region around. So due to the going easy, taking things to the basic. So the most important things in the clinic when we are in the beginning of our life is the psychology of those patients. You have to remember that all patients coming to your clinic, they are not coming to you for the first time. So they are just moving around for so many clinics. They are meeting a lot of patients and they will come to you to solve their problem. So you have to go to be confident in your knowledge, to be safe enough in your practice to make good clinical examination, to put your hand in the most appropriate provisional diagnosis, and then you can make the facilities in your hand by test block, by just something you can combine pharmacological in the good way, and don't go and just give like anybody prescription of painkillers like this. So these are the challenges facing us in the first days, and this is how we are going to solve it in the first days. Nowadays, definitely something is totally different. I hope that I just, in the very quick time, I gave you some points of difficulties, of challenges, and how we solve it.
Thank you, Dr. Gadar. Thank you for sharing your Sudanese experience. Now, Pankaj, so you talked about marketing. So in the comment section, somebody has asked, as somebody who's doing pain practice, how much percentage of their income should they invest in marketing?
So percentage wise, I will say ideally should be 20% of your income. That you should be investing in the marketing, but obviously you have to see other things also. So there are two things. One is the either revenue and one is the profits. Now, it is always better in the initial phase of your practice, you have to see the profits. Don't go by just by the revenues, whatever you are earning. Because in the initial phase, the revenues may be, by number it is okay, but your expenses are also there. So if you're taking the percentage of the revenue, then it will, if you take 20% of that, then actually you are not earning anything. But once you start getting good revenues and you have a good profit margins, so in a hospital, in a clinic setup, in a center setup, we just call it as like EBITDA. EBITDA means like revenues before the tax and so that is called EBITDA. So is called EBITDA. So if your EBITDA is around more than 20-25%, that is the time when you are most comfortable. That is the time when you should be investing at least 20% of your revenues into the marketing. Okay, so you have to learn little bit about management part also. It is always good to learn little bit about management terminologies and how to calculate your expenses, profits, and revenues. All these things we must learn because we are actually very poor in that. We don't see all those things because there are some calculations. The economics depends on a lot of calculations. So depending on that, we have to invest. So don't consider marketing, whatever you are putting in the marketing, don't consider as a waste. That's an investment. That's an investment. Because with that 20%, you are going to grow. Definitely your patients are there. Word of mouth is one of the best marketing. But again, the word of mouth, you should try to capture those word of mouth in the form of your reviews from the patients. Let me tell you that online marketing, the most important thing, these IT people, this younger generation, whenever they'll see you, they'll first go to see your reviews. That is the first thing what they're going to do. They will not just look at you and that, oh, there is a degree. Earlier, this used to happen. maybe around 10, 15 years back, it was used to happen that they used to see the name of the person and then the degree, something USA is written or something, some Western countries written in front of degree. Then they used to believe that, yeah, oh, he's a good doctor. But now it is not that. Now people are going for the reviews. They see your reviews and then they only come to you. So invest in that. That also comes into marketing. So at least 20% of the revenues, once you are advertised more than 30, 25%, in those cases, you must go for the 20% of your marketing, revenues marketing.
And considering COVID, you're saying currently it is better to invest majority of your marketing in online marketing.
Online, basically online marketing, one is online marketing. So online marketing for the online consultation.
Okay.
Marketing for the online consultation. So you have to spend money for the online marketing for your online consultation, because that is another good area which is going to come, because you know that we have a telemedicine guidelines are there now, and there's a basic law which has formed, and under that law there are some restrictions are definitely there. So you have to take care of those restrictions while doing online consultation. What I will prefer is that it is always better to do video consultation. Don't do chat consultations or the text consultation or the phone consultation. That is not a good way of doing online consultation. Wherever possible, always insist for the video consultation. You know that it is, when you do video consultation, it is actually like you're seeing the patient in front of you. The only thing which is missing is a physical examination, but that is also possible. You can tell the patient, lie down and ask somebody to do whatever maneuvers you want to do, whatever you do normally. You can see that things also. But once you see the patient, you also get a confidence. At times this happens when you do chat consultation or the text consultation. Patient is in the serious condition, but what they are telling is that it's a normal pain or something like that. Okay, but when you see actually the patient is in bad condition. Okay, so you must read the online consultation guidelines. Very important. We just had a session on this thing. It is not mandatory. If somebody has taken consultation, online consultation from you, you can always refuse. Even after the consultation, you can always refuse the patient that I will not send any medicines to you. You'll have to come and show to me physically. You can always refuse that. Okay, so that is the legal part, but marketing part, I'll say that online consultation, definitely very important thing is that for online consultation, keep a slot. Maybe 1 hour in a day or 2 hours in a day, if the number of online consultations are increasing, keep a fixed slot. That is more important. You have to have a fixed slot for that. You just cannot do that like that. Okay, today morning he takes a consultation in the morning, or he can take any time. Don't do that. Don't keep it open for throughout day. You are inside OT, patient has taken an online consultation, you are not available. Then the frustration comes. Then he put a bad review. Okay, so that goes against you. Okay, so keep a slot ready for that. Start with a 1 hour, just 1 hour in a day. That's it. Once you have crossed 3-4 online consultations, then you can go to 2 hours in a day.
Right. Okay. I'm going to go back to Dr. Das, and since he's the pioneer, and ask him, as a young pain physician, what are the things that they should keep in mind while establishing practice and all this? Pankaj is talking about website, he's talking about online presence, reviews, social media. So what is his take on all this?
The situation, normal situation and the COVID situation is a little bit different. So before the COVID situation, the things was like what Dr. Pankaj told, like the free camps, then the seminars was very important. Like those who are working in the, like Jesnu is, facing difficulties in getting referrals. So Jesnu and others who are practicing in a corporate hospital or in a medical colleges. So they should be frequently organizing seminars inside the hospital, inviting the other specialties, so that many of the other specialties do not know what can be done. It's not always, the front, the desk people should be blamed. Sometimes it is true that they are calculating money. What Karthik told, I also have similar kind of things. When I went to visit the corporate hospital CEO, he simply calculated that, okay, disc prolapse case, if you are giving a transferable and epidural, the hospital earning will be 5,000. But if that disc prolapse case is going to a neurosurgeon, the hospital earning will be, the few lakhs. So why shall I, send this patient to you? So that is keeping that part apart. Even nowadays, when the interventional pain management has advanced a lot, when they know that this can be earning reputation to the hospital also, if somebody is not needed, the operation. So that is basically adding reputation. So what is more important is front desk people should be taught. Front desk people may not be aware what we can do. The other specialists, other people who are sitting in the emergency room, other in the those who are doing in the OPD in the rheumatology clinic, those who are sitting in the orthopedic clinic, in the medicine clinic, they might not be knowing what we can do. I have seen that the patient was referred to me. They are telling that, okay, patient is himself a doctor, or sometimes referred to me, sir, I have been referred by such and such doctor. Just do a pain relief for me. So I told, okay, only pain relief is not possible. We have to make a diagnosis, and according to that, we have to do the treatment. Only pain relief, there is no such word. So the thing is, we have to make the other people aware, and for that, we have to making the seminars. So seminar, nothing like seminars. Seminar with the other specialties, as well as the camps, awareness camp, what can be arranged with the other the paramedical staffs, reception staffs of the hospital. And even this kind of camps can be organized among the other societies, like say for example Lions Club, say for example some of the other clubs in the localities. So these all can be organized for making the awareness as well as the practice. But right now at this situation, COVID situation, all these are not possible. So right now the only thing is what is possible is your social presence in the social media, with online marketing. So these are the things where you have to put more emphasis. And as soon as the COVID period is over, so you should be arranging this kind of camps, this kind of seminars with the doctors, with the other people.
Thank you, sir. Now, I'm going to quickly ask Dr. Palak Mehta. She runs a very successful pain practice in Ahmedabad. She's very fond of giving TV interviews. So I'm going to quickly ask her, how effective are TV interviews in establishing pain practice? Dr. Palak.
So basically doing TV interviews are like, sometimes you got calls, so you are sharing your ideas, you can ask some leading questions, and you can share that this kind of pain may be from this way and you may not require surgery. So ultimately, like Pankaj said, it is a kind of modified consultation, modified online consultation, I would say. So now patient will come to know that Dr. Palak Mehta is there. They may search on the Google, or when I was doing my interviews, I have stopped since last 1.5 years because I have number of patients, so it's not needed. So currently we are doing online marketing right now, but yes, it was effective, and I have done almost for 1 year. Almost around every week there were interviews, and in that, though it was planned, so I was showing some procedure that how it is done. I was going with the spine model, and I was explaining the procedure in the way it was done. But Pankaj said it very rightly that you must need to have your own center. Corporate is not going to help you in any way. Unless until you come out of it, then only you can promote yourself. And till today also in my practice, there is only 5% referral work. 95% work is from your patient to patient, from online marketing, and this is what it works.
Yeah, so Dr. Palak is saying that only 5% of patients in her practice are actually referred, and 95 patients are patients who she reached out to the public, and patients referring from each other. So that's something that the junior should take home. So majority of practice is your own. So the way personally I would consider it is, if somebody refers a patient to me, I would consider it as a bonus rather than expect a referral. So that should be the outcome. Of course, you know the practice in India. So there are things like you may have to give somebody a referral fee and all that. So that's again another headache, which you can, it's an option that you should essentially take. Okay, coming back to Pankaj, now that you're saying so and so things can be done to establish practice, and you yourself, you took it to the next level. You started doing advanced procedures, you started doing stimulators, intrathecal pumps, endoscopic spine procedures. As a physician, when do you confidently say that, yes, I'm qualified, I can confidently do advanced pain procedures, I can do vertebroplasties, I can do endoscopic? When do you say that?
Karthik, here again, there's a difference when we started practicing and what the practice is now. There's a difference in that, because that time, what used to happen that suddenly we used to get some patient and we had to do procedure. We had no training that time. Everything we learned by just going through the books. Like I just take one example of my first vertebroplasty in 2008. That was a very interesting case. This patient was lying on bed in a hospital. So I was called to see this patient, and why I was called? Because to take care of the pain management. So they said, we have tried everything, we are given everything, he is not having relief. This young guy, he was a young guy, 42 years. So he had a fall and that he had a fracture on the spine. So we have tried everything, he is not getting relief with anything. Can you start some fentanyl infusion? For that, I was called. Okay, so I saw this patient, I saw that, okay. So I was just discussing with that surgeon, orthopedic surgeon. I was just telling him, because I also had read only about vertebroplasties. I had never did something. So I told him there's something called vertebroplasty, you can do vertebroplasty. I was telling him, you can do vertebroplasty also in this case, this is a good case for this. So this guy the gentleman who was lying on the bed, he heard our conversation. He called me and he said, doctor, you were discussing something about that procedure. So you'll have to do that on me. I said, no, it's not possible. It's not possible. It's been only 12 days. So that time, if you remember, in 2008-9, that time, the recommendations were you have to wait for 6 weeks before you decide for the vertebroplasty.
Not only that, Pankaj, I can remember you also consulted me about this patient. And I told that, okay, it is a traumatic fracture. Don't do that. Traumatic fracture was a contraindication. Traumatic fracture in a younger population is a contraindication.
Absolutely, sir. Absolutely. Yeah, that was a contradiction. Sir said it's a contradiction because that time traumatic fracture was not there in the indication. Later it was added. That time it was not there. That time only 3 indications were there. So definitely, so what happened that before that? So he said, this gentleman said, either you do that procedure, otherwise I'll commit suicide. Those were his words. Why? Because he said, I'm the only earning member. It's been 12 days I'm lying like this in the hospital, and this doctor is saying that you'll have to lie down like this for 3 months. Because that time it was there, like 3 months you have to lie down like this. So I said, it's not possible to do it on 12 days. He said, no, either you do it, otherwise I'll commit suicide. Then I called Dr. Das, and then I started reading about this thing. And the next day we had to take that patient. I had to take that patient inside. And that is how I did my first vertebroplasty in 2008. And the interesting part was, the same day patient was walking. Next day we discharged the patient. There was a huge popularity about the procedure. That just a small keyhole surgery was done. So next day, the owner of the hospital, he called me. Come to my house. Come to my house. My mother is lying since last 3 months. She's bedridden since last 3 months. She's having 2 level fractures. Can you do something for her? And can you imagine, third day, we took that patient and we did 2 level vertebroplasty. So this is how we learned. But definitely, now the scenario is different. Now the scenario is totally different. Now people are aware of the pain medicine, what are the procedures are there. And the good part is that now the young pain physicians, they have a backup. That time it was not there. Okay, now you have backup also. So even if you have in your initial practice, even if you have some cases, difficult cases or the advanced cases, don't do it yourself. You have a backup, you have somebody senior around you, you call them and do the procedure in front of them, or maybe let them do. Learn properly. Because this is not the way how we learn. That is not the correct way of learning the procedures. That was actually because that was forced on us. But that is not the correct way, because now you have a good method of learning the procedures. So advanced procedure, I would say, you should not take independently at least for 2 to 3 years. At least for 2 to 3 years of your practice. Only after that you should go for good trainings, keep somebody with you for the initial few cases, then only you start doing. It is always better.
Yes, essentially what happened was when we were trying to establish the specialty, we did not have structured long-term pain training programs. So if you see, like people like me and Pankaj, we sort of learned from Dr. Das, Dr. DARADIA, these people. And if you actually see Dr. Das, he is pretty much self-taught. He learned all of this pretty much by himself, and he learned it from books. He learned it from what his colleagues in the Europe and US were doing. So to establish, we had to do it in a difficult way. Now that structured programs are there, it may be a little bit more organized, and it has to be algorithmic and stuff like that. Okay, coming back to
not only that, Karthik, that was the time where the medical legal things was also not very difficult, not very so much tight, So right now the medical legal things are going, more and more vast against the doctors. So we have to take care of us in that as things also. So, when we started and when now people have started, they should be more careful at the beginning.
Right. I'm going to ask Pankaj a few more questions. Meanwhile, the delegates, if there is anything else you want us to ask Pankaj or discuss, please feel free to put it in the chat box. Now I'm going to ask Pankaj, now that we talked about doing basic procedures, we started doing advanced procedures, full-fledged pain practice. If he were to face a complication, how he manages it, and what should be his advice to the juniors when he faces complications during interventional pain practice?
Yes. So the most important thing when you land up into complication is that tell yourself that complications do happen. Complications is not negligence. Remember one thing. Complications do happen. Face the complication. That is the most important thing. Face the complication. Which means if you have a complication, accept it. Accept it. Again, which means that if you have a complication, then now you have to be more careful about that patient. This is earlier what used to happen, and we still see that whenever the patient comes with the increased pain or some complication, the first reaction of the doctors or the, I'll not say pain physicians, general as a doctor, they just try to avoid that patient. Never ever do that. Never ever do that. This patient who is having complication, he will go to 10 places and everybody is going to tell, because of this procedure, this has happened. Now the thing which was not very, it's a complication, now it has become complicated medical legally also. Okay, because some of them somewhere, they will say, why don't you do a case against that doctor? Somebody is going to advise him. So this is going to happen. So whenever you have any complication, accept that complication. Tell the patient, very clearly tell the patient, yes, this is one of the complications and probably this has happened. Then investigate properly. Write down completely that we did this procedure and this is what we are suspecting that this is complication which has happened. Write down that complication. It has to be in the writing. It has to be mentioned in the case sheet. Okay, because this is going to save you. And then once you have investigated the complication, you have come to some diagnosis, then start treating that complication. Again, write down everything, what is the plan, next plan of action, everything should be in the written. And you should have a copy of that. Now, suppose, even after that, if the patient goes to the court of the law, what is going to happen? The court or the expert panel of doctors, what they are going to see is that whether this doctor who has done the procedure, he has he has detected the complication, firstly, whether he has managed the complication or not. These two things they are going to see. If you have done these two things, it will never come into negligence. But if the patient comes to you, if you send the patient without any investigation or without any mentioning of the complication, that will come as a negligence because you have neglected the patient. And then you are liable for the in the court of the law for the punishments. So remember, don't be afraid of the complication. Again, confidence comes here. Confidence, you should be managing that patient in a confident way. Don't show your this thing that, oh, I'm afraid of this complication. Don't show that on your face. Say, yes, this happens. This happens in 1 in 100 people, 1 in 10,000 people, 1 in 1,000 people. This may happen. You have this complication. This is a mentioned complication. We are going to manage this. Don't worry. You have to tell them. You have to assure them also that you are going to manage the complication. Okay, so that is most important thing. Detect the complication, notify the complication in your case sheets everywhere. Keep a copy of that and manage that complication.
Right.
Yes.
So, yeah. So like Pankaj rightly pointed out, most important thing is whenever you feel the complication, don't run away from this patient. You have to talk to the patient. You have to talk to the attenders, reassure them, tell them there is a possibility something could have gone wrong. This has happened. We will tackle it like this. So if they feel that you're neglecting them, it crosses more problems for you and for them. So that's not the way forward. Whenever you face a complication, try to talk to this patient, try to talk to the attenders, reassure them. If you think you require help from another colleague, you might as well consult with them, get them also involved, and try to sort out this problem. If you, we've all faced complications. If you realistically go face to face with them and tell them, yes, this is what I expected, something has gone wrong. This so and so percentage of complications are there with all procedures worldwide, and this has happened. So we are going to treat them like this. They would accept it. So the most important thing is face complications, talk to these patients, reassure them, rather than sending them away or running away from them or neglecting them. That would result in more problems, right?
Kartik, I used to add one thing along with this. Thing is, this at least some indication of this complications should be given beforehand. Means, suppose if you have not talked about any complications before doing the procedure, and suddenly you are facing the complication, you are talking to the patient, then patients may be reacting in a in a different way. So what is also important, that before starting the procedure, when you are taking the consent of the patient, we must be telling that these are the potential complications. We should be telling that these complications are very rare, extremely rare. Like I tell, this is like sometimes some complication I tell guys, like, if you are sitting here, if you are moving in the road and some car is coming and there is an accident, so it's a possibility, but it's a rare possibility. So, it's similar kind of accident can happen, but these are extremely rare. Usually we don't see this kind of complications. But we have to tell this beforehand also. Otherwise, if you are telling after the complication is happening, then patient's reaction might not be that pleasant.
Yes. So very important that when you do the first consultation of the patient, that you spend some time with this patient. So usually in my practice, I spend somewhere between 20 to 30 minutes during the first consultation. Now, one, you sort of go back and find out what is in the background, what sort of profile this patient is and stuff. And second is you sort of establish a rapport, saying that yes, so-and-so is a reasonable surgeon or a reasonable physician. Very likely you will get a good outcome. So unless you establish that rapport, very difficult to go forward. So see, you may be the best surgeon or the best physician, you may be the best person in the technique. When they leave your OPD, if the patient is not convinced that you are going to cure them, you can stand upside down, you will not cure them. So unless the patient believes and he's got belief in you, you have established a rapport, only then your treatment will succeed. So spend some time with the first consultation, talk to them, discuss with them what is realistically how much outcome, realistically how long this block will act, realistically what complication. we can tell them that this is rare, but yes, this does occur. So the initial consultation, when you tell them about this procedure, you need to explain to them, spend some time there, right? Okay, now in the
I just want
yeah.
to add one other thing here. This is regarding the complication only. So even if you have a patient who has come to you and somebody has done procedure and he has landed in complication, okay, and this patient is consulting you now, never ever blame that surgeon or whatever, whosoever it is. Never ever blame. Try to console that patient that yes, this happens in surgery, in interventions, in whatever treatment, this happens. Complications do happen. To try to console whatever you are going to tell, if it is your patient, same thing you have to tell for the other person also. If it is someone from someone else complication also, you have to say the same thing. This is how you are going to develop a good rapport. Because this patient invariably he'll go back to that surgeon. Definitely he's going to go back to the surgeon and he'll say, yes, doctor, that also doctor said that this happens and this is a complication. And okay, we can go ahead with the intervention, whatever next procedure is required. So this is how you develop a rapport. Okay.
Yes, yeah. Bad mouthing your colleagues is not a good idea at all.
Never do that. Yes, people do that, but you should never do that.
Right. So Pankaj, coming back to you, one more question in the chat box. How do you get medical insurance for your pain procedures? How do you go about it in an individual pain clinic?
So right now, I will say that currently, whatever we are doing some sort of, I'll say that here and there we are changing the terminologies or something we are doing to get the insurance. But let me tell you about whatever we are doing right now since last 3-4 months. Karthik, you are aware of that. Sir is aware of that. From the ISSP side, that's a wonderful thing which we are doing right now. We have, as you all know, that we have come out with some nomenclature system, coding system that was done last year only. But this year we appointed one consultant who is helping us in getting all the procedures. So we have a list of now 140 procedures. So currently we are doing a mammoth task of costing and the pricing of all the procedures. So we are doing the package system for each and every procedure. So it's a very, very big task. Every day we are spending 2 to 3 hours in that. Since last 3 months, I'm doing all these things. So we have reached to the stage that now we have the costing and the pricing of all the 140 procedures. Now on Monday, we are going to decide the package system for that, all the 40 procedures. And the most important thing is that we are going to ask these insurance companies, basically we are approaching first IRDI. IRDI is basically Insurance Regulatory Development Authority of India, IRDAI. Okay, so we are approaching Insurance Regulatory Development Authority. We are going to go to them and we are going to submit all these 140 procedures with the packages, costing, pricing, and we are going to submit to them. Once they approve that, then all the insurance companies, the private insurance companies, they are going to accept that. So this is the path we have taken. And all these procedures, most of the procedures, except for maybe for 5% of procedures, like some advanced procedures in the spinal cord stimulators or intrathecal pumps, most of the procedures we are asking for the daycare procedures as a daycare procedures. So this is once this is accepted with the IDA and with the insurance companies, this specialty is going to boom like anything. All the intervention centers, daycare centers, they will have these insurance at their own centers. Now we'll not have to be dependent on the other hospitals for our insurance patient. So if you ask me right now we are getting all the insurance, but we have to change some terminologies. Like if you are doing endoscopic discectomy, we only write lumbar discectomy because that is the nomenclature which is there with them. Endoscopy is not there. Okay, like whatever procedure, like fixation surgeries or something, some fusion surgeries, like for vertiplasty, we are writing fusion surgery also. So that is how we are doing right now, but that is not a correct method of getting these insurance. But once we have this insurance, everything in a full-fledged, foolproof manner, then it will be easy for all of us to practice. under insurance.
Okay, so
And not only that, Pankaj, sometimes we need to, keep the patient admitted. Unless it is admitted, majority of the insurance company do not allow it. That is one of the also basic problem. So what we are telling, this, these procedures are getting approved by this RDA, then that will definitely be a very good steps for us in practicing pain.
So that is what we are showing to the government. Basically, what we are showing them, that we can do all these procedures under daycare. So insurance companies, what they are seeing is that they are asking us how these procedures are going to benefit. Benefit means in their business. So we are showing them, if you do it under daycare, you are saving a lot of money. The same procedure which we can do at 40,000, if you admit the patient and do it, it will go up to 1 lakh. So you are straight away saving on 50% of your insurance money. So that is what we are showing them. We are already given them some procedures where we are shown them we can do all these procedures under daycare. And this is how much you can save. The insurance company can save. So that is the language they understand, the insurance companies. So we have spoken to ICICI Lombard and we have spoken to the Star Insurance Company, Star Health Insurance. So we have spoken to these two big companies, to their MDs, and we have shown them all these things. But definitely we have to go route, it has to be routed to the IDI. So first we'll approach IDI and then from there it will go to all the insurance companies.
right. Just to add on to this, what we are working on in the future, Pankaj explained. Currently, what we do, just for the sake of people who never claimed insurance, I'm going to sort of make it very simple for them. So I run a daycare center, right? So most of us run daycare pain clinics. In my clinic, I don't have a facility to admit anybody overnight. So my clinic closes at 8 p.m., everybody's out. So what we do is, essentially patients who pay by their own, they get the procedures done in my clinic, and they have an option of trying for medical insurance reimbursement for the procedures that is done in the daycare clinic. These patients may get, may not get. And usually the chances of getting reimbursement, if you have a corporate medical insurance, is more than a public health insurance one. So some procedures where the patient insists that they want to do cashless, what I do currently is I also work in Apollo Hospital, one of the Apollo hospitals in Chennai. So what I do is we send something called pre-approval. This is just for the sake of beginners. So we send a proposal through the insurance coordinator of the hospital that so-and-so procedure is going to be done on this patient for this condition. So if, let's say, you're going to do a transforaminal nerve root injection, you give a proof, which is that there is a disc herniation, by attaching the MRI report. This is the plan. This is the proposed amount. So you send this to the insurance company. Now, the insurance company may say, why you want to do this procedure and why surgery is not due. So they may ask for a clarification. You try to clarify. Most insurance companies, like Sir was saying, will ask for overnight admission. So in my practice, what I do is, if I do it in Apollo or in a corporate hospital, I will admit this patient in the morning, do this procedure in the afternoon. Sometimes for the sake of insurance, I will make them stay overnight and get discharged the next day morning. So that works sometimes. In my practice, I get insurance for almost all pain procedures. It includes cervical, it includes RF, it includes genicular, it includes lumbar, trigeminals, peripheral nerves, almost everything. But that's because I go through Apollo. It's possible that if you're going through other hospitals, you may not get. Now, this is fine. This works for me at least. Now, the trick is, we are trying as a society through Pankaj, what we are trying is, we are trying to get this for daycare procedures. So we'll be able to do like they do in the US. So basically, this is the system that exists in the US. So we are trying to get it for daycare procedures in our own pain clinics. So that would sort of make it easier. And if this procedure will sort of, the way I see it, will multiply the number of procedures that are done in pain procedures. So this will be a very, very important step for pain medicine in India. So what Pankaj and the ISSP is working on is a very, very important step for claiming insurance, medical insurance for daycare procedures in our pain clinic. So that will be really, really crucial step for us, right? Okay, coming back to Pankaj. So we are coming to the end of the show.
Can I add one thing here?
Yes, please.
So one request which I've been doing since last 2 years, start using the nomenclature whatever is there, with the ISSP approved nomenclature, because that is the nomenclature we are given to the insurance companies also now. So whatever procedure we are going to get approved, those are based on that nomenclature only. So you already have, I think everybody has received that those nomenclature that is there on the ISSP website also. Download from there and start using those nomenclature. Wherever you are working, you give this nomenclature to your HI system and feed it inside the HI system and start using that, because what is going to happen once these are approved, only these procedures will be approved. So if you are giving some other name, you may not get approval. So start using those nomenclature. We have a exhaustive list of 140 procedures, depending on the levels also.
Right. Okay. So that's something that you should consider. Maybe we should circulate this again in Facebook and social media. Okay. We're coming to the end of the show. Final one or two questions here. Pankaj, so pain medicine, how do you see the future of pain medicine in India? And what would be, see, I know a lot of guys who got trained in pain, they couldn't sustain and they went back to anesthesia. So what would you tell to the junior trained pain physician about the future of pain medicine in India?
So future of pain medicine, as we already discussed about the insurance thing, once it comes into insurance, it will be a major specialty. Not only that, also what we are seeing is that about the recognition of this specialty. Now we all know that now we have this FIPM by the ISSP, 1 year fellowship program, 1 year full-time fellowship program. We have recently got this fellowship by National Board. We recently got it approved in the month of June only. We got a notification in the month of March that from July onwards they are going to start a center recognition. So by January we should have first batch of the fellowship of National Board. It's a 2-year program.
FNB 2 years.
Yeah, FNB of two years. Fellowship of National Board. So that is another good development. Third development is now we have a DM in pain medicine also. If you know that in AIIMS Rishikesh, we have started this DM in pain medicine. So recognition wise, we already are getting good recognition of this specialty. Once it comes into insurance, then the business of the pain medicine will progress like anything. Once you are showing the number and the revenues, I'm going to tell you that all these corporate hospitals, they are going to establish pain centers in their hospitals, because what they want is revenues. They should see business in the specialty. Once it is under insurance, the number is going to multiply like anything. And once they see the numbers and the revenues, they are going to establish pain departments in all the hospitals, all the corporate hospitals. We have seen this change since right now we do not have that also, but we have seen that change in the corporate mentality also. Now they are accepting the pain departments. But once we start showing them the revenues, they will accept us like anything. So future is very bright, very, very bright. So what was your second question, Karthik?
So what's your take-home message for the young pain physician?
So take-home message is that the most important thing is that prepare yourself very well. Prepare yourself. Prepare means not just the training part, the practice part also. In your practice, keep your in 1 year, 2 years as a training part only. That initial practice part should be keep it as a training part. As Dr. Das mentioned that you must do some CMEs in your hospital. But I will suggest that whenever you do some course or something, don't jump for the CMEs. Again, what is going to happen, this we have seen a lot of time, that people just take a course and then they start doing CMEs. You are not confident. You don't have good knowledge. You may have theoretical knowledge. You must have read a lot of things in 1 year or whatever. But the practical knowledge is not there. When you are presenting in front of the different specialties, I'm talking about even the physiotherapist, when they put there some difficult questions, the practical questions, you are not able to answer those questions. And that is where you start deteriorating yourself. So once you have a good established practice, once you have a confidence in treating a patient, then you start doing these CMEs. Even if you want to do some CMEs or some education program, always keep some senior with you, like what Milton is doing right now. That's an excellent way of doing. That's a wonderful way of doing. He's selecting some senior pain physician and he's doing some CMEs along with them. So that is the best way of doing CMEs, initial CMEs. Once you are doing multiple CMEs with a senior pain physician, then you can take over. So that is the most important thing, is that prepare yourself. Second important thing is try to establish your own practice. Try to establish your own patients. That is very important. Don't depend on the referrals. Third important thing is that go with the technology. That is again very important. There is no age limit to learn anything. Whatever the new technology, especially in the pain medicine, every year new technology is coming. Every year we are adding something in the armamentarium of our pain interventions. Start accepting those. Don't say that now I'm crossed this age. Now this is not an age to learn. Even the person who is teaching is junior to you. Don't be ashamed of that. Learning from that person. So go with the technology. Whatever new technology is coming, you must learn that properly and you must adapt that. So these are my 3 take-home messages. Karthik.
Thank you, Pankaj. Sir, you want to contribute anything else? Sir, we can't hear you.
Okay, today is Pankaj's day.
Now you are.
Okay, Pankaj covered everything almost nicely. So almost nothing to add. So what he told about the Milton. So Milton is really doing nice. So right now the CME seminars are not possible physically. So this kind of online thing is what is possible right now. So they should be continuing like that only, and gradually developing your own practice and not depending too much on the corporate hospital.
Right. If there is anybody else wants to ask anything else to Pankaj, please put it in the comment section. So thank you, Pankaj, for sharing a lot of insights into pain practice and giving how you struggled through and established and became a successful pain physician. And you also shared with the juniors what are the steps that are crucial in developing pain practice, how you will establish practice, those sort of things. So thank you for sharing all these details with us. Thanks to DARADIA Pain Clinic. So we sort of wanted to do programs where we are like basically doing a case discussion series every fortnight. And in between the first and the third week, we are trying to talk to senior pain physicians and sort of extract information which may be crucial for junior pain physicians. So this is something which we thought will help pain physicians to sort of establish their practice, to basically reassure them that what they are doing is correct, and some tricks that we may be able to offer you to establish your practice in a little bit better way.
What I'll be telling others, juniors also. So the first and third Sunday, some of the senior pain physicians will be coming. So juniors can also ask certain questions, the problems they faced in their practice. Like, suppose somebody has, some trouble, some hurdles in their practice. It might be related to a particular patient. It might be related to something else, some things like, marketing, promotions, whatever kind of problems they are facing in their professional life. They can ask, seniors, pain physicians, and ask the helps from them. So that also, that will be the welcome questions from the participants, junior participants, so that will be helping their practice.
Right. So we will be continuing in the future as well about these programs. So case discussion series and the talk to senior pain physician series is very much on every Saturday at 5 p.m. from DARADIA Pain Clinic. So thank you all for joining us. Thank you, Pankaj. Thank you, sir. Thanks to all the delegates for joining us. Happy Independence Day to all of you. Stay safe and see you during the next program. Thank you very much.
Okay, thank you all. So see you again on next Saturday at 5 p.m.
Thank you very much.
Thanks, Karthik. Thanks. Bye-bye.
Thank you. Thank you. Take care. Bye-bye.
Bye, Palak.
Thank you.
Thank you. Well done.
Bye, everyone.